Hi everyone. Today's lecture is on the ribs and the sternum. Here's your anatomy. As you know from the chest x-ray, the ribs are numbered according to the thoracic vertebrae that they're attached to. The ribs are long and narrow and curved bones, fairly thin. They're thicker at the top and shorter, and thinner at the bottom and longer till you get to 11 and 12, and then they get a little bit smaller again. So from anterior to posterior, the ribs anteriorly lie much lower. They drop about 3 to 5 inches compared to the posterior rib where it connects to the vertebrae. So you'll see the anterior ribs most easily on your chest x-rays, and then the posterior ribs on the chest x-ray better than the anterior ribs. And you can't see the costocartilage where they are attached here in the front at the sternal end, because the cartilage just doesn't show up on the images. So the ribs vary in length and breadth. They increase in length from number 1 to number 7, and then they begin to decrease again to 12. They're classified by their attachment. So true ribs are pairs 1 through 7, and they attach directly to the sternum. And false ribs are from 8 to 12, and they attach indirectly to the sternum at the coastal cartilage. The floating ribs don't attach to the sternum at all. That's why they're called floating. They are just in the back all by themselves, only attached at the vertebral end. So the bony thorax protects the sensitive organs in the chest. Its structure allows it to expand and contract with the breathing. I just find that amazing how the body works. It's just fascinating that it can be structured so that it allows for things to move and the articulations and all of that. But maybe that's just me. Maybe I'm just a nerd that way. So the rib articulations you can see here at the spine. Those are when we talked about the T-spine, the whole facets and demifacets you learned about. The rib head articulates with the vertebral body, and the tubercle articulates with the transverse process. So costo is rib, chondral is cartilage, and the cartilage makes up the space from the anterior end of the rib and connecting to the sternum. So you can see all of the costochondral joints are here, and they're attached. Yes, somebody was at my door, but sorry about that interruption. Okay, so here you have a little bit more detailed anatomy of how things connect to the thoracic vertebrae and the different parts of the rib bone itself. I'm not going to read it to you. You guys can manage that on your own. And here is your sternum anatomy. So you can see on here, you can see where the clavicle attaches to the manubrium and where the first rib connects. It's typically, the sternum is difficult to see on an image because of all the anatomy surrounding it. So you want to be sure you're centered on the midline of the anterior thorax. The manubrium's a flat, narrow bone. It's about 6 inches long, including all the parts. The manubrium at the top has the jugular notch, which you use quite often for landmark, and it's approximately at T2, T3 interspace. And the body's the longest portion of that 6 inches, and it makes up about 4 inches of that. And the xiphoid process is at the very bottom. It's the tip at the bottom, and the process is really very small. So the manubrium is probably 1.5 inches, and maybe the xiphoid is 1/2 inch. It's usually, some people have a pretty significantly sized xiphoid. So, as with everybody, though, depends on the size of the person and their anatomy is always a little different. But the xiphoid is about at T10, so that helps you know exactly where you lie. And here is your a slide with all the anatomy that we just talked about. So you have it here where you can see it as well. All right, patient prep, just like a chest x-ray, really, everything from the waist up off, jewelry, things like that. So you guys have that down. Don't just remember anything on the chest that needs to come off. Don't have the patient's bra on. You can. I've seen some images with the bra hooks in there. You don't need to be seeing that. Most of the rib views are 72 inches, and your cassette or your image receptor is going to be crosswise if you're doing a PHS or bilateral ribs, and lengthwise for unilateral ribs. Use the large focal spot. Full inspiration for the upper ribs. It's best like with your chest x-ray where you have them take a deep breath in and then blow it out and then take another deep breath in, because you want to be able to see plenty of ribs up above the diaphragm. Your image receptor is going to be about 1.5 inches above the border of the shoulders. Center at T7, just like for chest x-ray on the upper ribs. And your markers need to be out of the way. I don't want them superimposed over any anatomy, so you have to be really careful where you put the marker. Just make sure it's up, usually up and out to the side. If you're doing the lower ribs, you might think about putting it lower, but for the upper ribs, you want it up and out of the way. Shielding all of your patients for the ribs. Standard views, you're going to do PHS, and they typically will do that to rule out any underlying injury to the lungs, or because you can see on this particular view, there's a rib fracture down here low, and there is a pneumothorax. The edge of the lung is over here, not where it should be, and there's some air that has escaped into the tissue that's up here. Once it escapes, it rises if the patient is upright, and it's up there by the neck in the tissue. It gets a little crinkly sounding too on the patient if you touch it. It's kind of creepy. Anyway, typical views, RAO, LAO, depending on the area of interest, or RPO, LPO, also depending on the area of interest. So if the patient has pain anteriorly, you will put that part closest to the image receptor. So whether you do RPO or RAO will definitely just depend on where the patient's injury or pain is. If possible, you need to mark the area of concern with a BB so that the radiologist can correlate with the images. So pneumothorax, subcutaneous air, and rib fracture down at the bottom. And let's see, what else? All right. These are a couple of views. You want to have good rib detail. So you have to adjust your technique to make sure that you can see rib detail. So if you've done a PHS, that's a different technique than you would use for an AP or PA rib. Keep your collimation open top to bottom so you can include as many ribs as possible, and collimate side to side. So if you're doing just unilateral, you would do your PHS and maybe AP cone down view of just the ribs in the upper part, and maybe the same thing in the lower part, but just on the one side that's injured if it's ordered as unilateral. If it's bilateral, you would leave it open side to side. You want the collimation just to be just outside the skin line, maybe 1 inch outside the skin line, so that you don't, you can keep your detail a little bit better and your scatter down. If your patient is smaller, of course, use a smaller image receptor. All right. Also, when I come out for the site visits, I want you to be able to label which anterior and posterior ribs that you see by number, and remember that the anterior ribs are going to drop about 3 to 5 inches depending on the patient, so that they are when you're counting them, you'll know that the anterior ribs are going to be much lower than the posterior articulation. Okay, so one other thing, this is the full inspiration for the upper ribs, okay? Now we're going to do the AP lower ribs. Why do you suppose that you only do an AP on the lower ribs? I'm going to ask you that on your quiz. This is the only rib view that is at 40 inches. And I want you to think about why that may be as well. So with the lower ribs, you want to have a full expiration, and that elevates the diaphragm and gets it up out of the way. You need to see 8 to 12 ribs typically on that one. You're going to adjust your technique, and you're going to bring your distance into 40. So the shorter SID results in a greater magnification of the anatomic structures that are anterior to the ribs. And also, it's going to result in a better field of view for the posterior ribs that are up against the image receptor. Keep that in mind for the sternum as well. All right, here's your instructions. Basically, the AP and the PA are very similar, and the difference I'll go into in the next slide as far as where how you determine the difference. So the oblique views of the ribs are a little bit confusing as far as when you're looking at them and determining. If you're looking at an image and doing an evaluation, you need to be able to determine, is it RAO or LAO, and is it RPO or LPO? So typically you're going to have the RAO and the LPO. The image is going to look almost exactly the same. So telling whether it's anterior or posterior, you have to, evaluate for magnification and things like that. But most of the time with RAO and LPO, the right ribs are foreshortened and the left ribs are elongated. If you're doing unilateral ribs, you want the affected side. On the PA, the affected side is away from the IR, and if it's an AP, the affected side is closest to the IR. Having your markers on there correctly is really, really important. And once again, you put the injured part closest to the image receptor. So that helps you determine whether you're going to do PA or AP. Okay? So also one of the things I look at when I'm looking at these oblique rib views is recognizing that there's a Grashy view here of the shoulder, and there's a Y view over here of this shoulder. So sometimes that helps you to determine if your positioning is good, and a lot of times it can help you determine which position it is. So I want you to evaluate this image based on these positions and decide how you're going to remember when you'll see a Y view, a Grashy view, and which side is closer or further away from the image receptor. And when you're in lab, you're going to have a chance to really review those. Here's the opposite, LAO, RPO. Once again, the image looks the same. Here you can see your Y view and your Grashy view right over here. So on these views, you want to have proper collimation. You want to make sure that if you're doing unilateral, it'll depend on your site, but if you're doing unilateral, you're going to have just the one side on the images. If you're doing bilateral, you're going to open your collimation and use a larger crosswise image receptor so that you can see both sides.